Hello, this next session covers antepartum hemorrhage. The key learning points that we want you to take away today are to recognise the signs, symptoms and main causes of major antepartum hemorrhage or APH, and to understand that there can be some non-uterine related bleeding. Another one is to understand that placenta accreta should be considered in any pregnant woman who has a low-lying anterior placenta and who has had a previous caesarean birth. Major APH is an obstetric emergency that requires multiple simultaneous swift actions, and it's important to involve senior members of the multi-professional team early, including the neonatologist. And finally, the use of major APH clinical algorithm must be used to direct management. So we're going to start with some definitions. Antepartum hemorrhage is defined as bleeding from the genital tract after 24 weeks of pregnancy. Vaginal bleeding can be from the mother or it could be from the baby, for example in a vasa previa. The college provides a green top guideline which categorises the severity of APH based on the amount of blood loss, although it should be recognised that bleeding could be concealed. These definitions are categorised into minor, which is less than 50 mils blood loss, major, between 50 and 1,000 mils of blood loss with the woman showing no signs of clinical shock, or a massive antepartum hemorrhage is over 1,000 mils blood loss and or the woman showing signs of clinical shock. These next slides cover some national reports and recommendations for antepartum hemorrhage. Embrace has highlighted the fact that there have been delays in referral of pregnant women presenting with recurrent vaginal bleeding, particularly with a history of cervical abnormality or screen positives. Where there's been a high index of suspicion, it's important to refer for further investigation during the pregnancy rather than waiting until afterwards. For example, in the case of a genital malignancy or if there has been any vaginal trauma, it is important to think of these possible causes as opposed to only uterine causes. Several reports and the Mind the Gap project have highlighted the difficulties in assessing the clinical signs and symptoms in patients with darker skin pigmentations. The Mind the Gap project provides a free clinical handbook which can be downloaded describing these clinical signs and symptoms. I'm now going to talk about the incidence and causes of antepartum hemorrhage. Incidence. So APH is an important worldwide cause of perinatal mortality and maternal morbidity and thought to complicate 3 to 5% of all pregnancies. It is associated with preterm birth, caesarean birth, postpartum hemorrhage, blood transfusion, intensive care admission, hysterectomy, sepsis, venous thromboembolism and death. The causes of major APH can be multiple, but there are several important causes that we must not forget. These are placenta previa and placental abruption, as these can be life-threatening. Ruptured vasa previa may cause catastrophic antepartum hemorrhage for the fetus, but is not commonly associated with apparent major maternal blood loss. The clinical presentation of major APH can be varied. A woman with an APH most often presents with vaginal bleeding. However, this bleeding could be concealed, and in the case of placental abruption, will be within the uterus and it shows a sign of a tense, woody hard uterus with severe abdominal pain, and these are the key features. APH should always be considered in any pregnant woman with signs or symptoms of shock or collapse. An abruption can also lead to fetal compromise due to the disruption of placental perfusion, and the first sign of an antepartum hemorrhage could be an abnormal antenatal CTG. The following table shows the causes and clinical presenting features of antepartum hemorrhage. The next slide talks about abnormally invasive placenta. So abnormally invasive placenta is an umbrella term for a placenta that implants with a varying degree of invasion into the uterine wall. This means that it cannot be separated after birth of the baby. Abnormally invasive placenta can range from abnormally adherent or deeply invasive placental tissue, in some cases invading other organs. Reported to occur in between 1 in 300 and 1 in 2,000 pregnancies, it's associated with high rates of maternal and neonatal morbidity and mortality. Worldwide, the incidence of AIP is rising in parallel with rising numbers of caesarean births. The Royal College guideline makes a series of recommendations for diagnosis and management of abnormally invasive placenta. There should be a high index of suspicion in an anterior low-lying placenta if a woman has had a previous caesarean birth. In this country, it is also recommended that these women are referred to an AIP centre where they can get multidisciplinary team management. Well, I'm next going to talk about the initial management of antepartum hemorrhage. So the management and assessment of major antepartum hemorrhage requires multiple swift actions and assessments of both mother and baby. Blood loss should be weighed and documented, as with PPH. The amount of blood loss should be considered to be in proportion to the mother's weight. Once initial emergency management has commenced, plans for expediting the birth should be considered, and they should not be delayed for fetal reasons, for example, corticosteroids. Birth is most commonly a caesarean section and should be performed by the most experienced obstetrician available. If the consultant is not on site, they should be called to attend. Options regarding anaesthesia should be a joint decision between the senior anaesthetic and obstetric team with discussion with the woman where this is possible. And staff should be aware that APH is an important risk factor for PPH, and active management of the third stage should be recommended along with early recourse to tranexamic acid for PPH treatment. The neonatology team should be contacted early. The next few slides cover the emergency management of antepartum hemorrhage algorithm. So initial actions to be taken with major APH would be to lie the woman in left lateral and provide high flow oxygen. Next step, 2 large bore cannulas, and consider which blood test to send. These should include full blood count, a clotting screen, including fibrinogen, and a cross-match. It'd be worth considering point of care testing in conjunction with your anaesthetic team. Next, provide fluid resuscitation, and then after that, assess fetal well-being in the form of CTG. Assessing the patient. So observations should be recorded as normal. The next thing would be to consider what might be causing the antepartum hemorrhage, and to do that, need to examine the patient abdominally and vaginally, as long as you know there's no diagnosed placenta previa. Next, blood loss should attempt to be recorded, and weighing blood loss is really important, and the next slide we'll talk about that. So this slide gives you information about the dry weights of things that are commonly used on labour ward. Next step in the management of the antepartum hemorrhage would be to stop the bleeding. So it should be considered if birth needs to be expedited or not. This will commonly be a caesarean section and will be a decision made by the multidisciplinary team. So caesarean birth will happen in theatre, and then after delivery, assessing where the bleeding is coming from and how best to manage it should be documented. The next stage will be to consider the third stage. So active management is really important with symptometrin and considering the use of an oxytocin infusion and tranexamic acid where possible. Blood loss should be continued to be weighed and documented. And then afterwards, it's really important to think about what sort of monitoring you might need. Most commonly, this would be high dependency care. Inserting a urinary catheter to monitor urine output would also be considered important. So once you have successfully managed your antepartum hemorrhage, it's important to document events. This slide shows you a template which you may already have on your unit. It's important to record the cumulative weighed blood loss, document ongoing and repeated assessment of the woman, and to provide multidisciplinary team reviews even after the event. Post-event planning, so ongoing care for the woman, and documentation of a clinical incident form for the department. Debriefing the mother and birth partners at an appropriate time would also be really beneficial, and also debriefing the staff involved. So in summary, the key learning points from this APH talk are to be able to recognise the signs, symptoms and main causes of major antepartum hemorrhage, and to understand that there can be non-uterine related bleeding. Understand that placenta accreta should be considered in any pregnant woman who has a low-lying anterior placenta and a previous caesarean birth. Major APH is an obstetric emergency that requires multiple simultaneous swift actions and early involvement of senior members of the multi-professional team, including the neonatologist. Use of the major APH clinical algorithm can be used to direct management. Thank you very much.